Okay, so hi everyone. Thank you so much for attending today on this beautiful Friday. Um, my name is Dr. Chesney Ward. I am an assistant professor of social work at Utah State in the College of Arts and Sciences. So today I'm going to be talking about end of life care, advanced directives, how to support patients and families. I have 10 years of experience working in hospice and healthcare settings, along with private practice and working in geriatric psychiatric care. So I'm really excited to be talking with you all about navigating end of life. And I hope that I can provide some resources for you all. I do want to also acknowledge my research assistant, Adele Till. She's an MSW student out of our Nephi campus. She's made contributions to this presentation, and she also works extensively with me on this research in aging and end-of-life care. So thank you, Adele. All right, let's get started. So what are the current trends in aging? So this chart is just an image of the projection of our aging population longevity. So the US population of adults 65 and older will nearly double by 2050. Therefore, this demographic shift increases our demand for end-of-life care services and continued resource support for our aging population. This growth is driven by the increase in life expectancy from our baby boomer generation. Approximately 10,000 Americans are turning 65 every day. So as this population ages, we're facing higher rates of chronic conditions like heart disease, diabetes, dementia, cancer, all of which require specialized end-of-life care planning and support. Our healthcare systems are already experiencing a strain from this transition. The Bureau of Labor Statistics projects a need for 1.1 million additional nurses by 2030, with geriatric and palliative care specialists in particular in high demand. Additionally, our family caregivers, who provide an estimate of $470 billion worth of unpaid care annually. So we will also face increasing burdens as our elderly population grows. 70% of our aging population are unable to make medical decisions for themselves. These are people that are 65 years of age and older. 33 of adults currently have completed an advanced care directive. So this could include a power of attorney, a medical power of attorney document, a living will, etc. But those that do complete an advanced directive ahead of time, 80% of those persons report reduced stress. So planning ahead can prevent family disagreements. We all know that there's these family members that come out of the woodwork, wreaking havoc, causing stress on the main caregivers. So making it more stressful for the patient and client if they've not informed the family of their wishes. But if we plan ahead, we can make it more likely that care aligns with our personal values, our personal wishes, our personal goals. But we also have to consider cultural differences in completing advanced directives, which I will talk about in some later slides. Okay, so let's go over some terminology that we may hear if we are working with older adults who are wanting to complete advanced directives or are in need of planning assistance. End of life care. This is support for people in the final phase of their life, focusing on comfort, dignity, and quality of remaining time. So essentially, end of life care is quality over quantity. It's symptom management. We also have palliative care, which is specialized care focused on relieving symptoms and stress of serious illness, regardless of prognosis. So palliative care persons are still able to see their specialists. So they're still able to see their oncologists and whatnot. Hospice care. So this is care for those with terminal illness and life expectancy of 6 months or less, emphasizing comfort. Hospice, as we all know, can go longer than 6 months, or it can go less than 6 months. We've also can have people, we call it graduating off of hospice. And that means they no longer need end-of-life care and they can transition to home health or palliative care. And then finally, advance directives. So these are legal documents specifying a person's wishes for medical care if they're unable to make decisions. So what are the various types of advanced care directives? Well, first we have hospice versus palliative care. So I really wanted to emphasize what the difference is because sometimes it gets confused. So I just wanted to be able to provide some clarity on the two. So hospice care is for people that are diagnosed with a terminal illness. So their physician has stated that they have less than 6 months or less to live. It focuses on comfort versus curative measures. So symptom management, pain management versus curing whatever is going on. It's usually provided at home or a skilled nursing facility or an assisted living facility, typically wherever the patient is at. It's typically covered by Medicare insurance. I've also had patients that did not have insurance, and so they're deemed indigent, which means they're uninsured. We still care for them. That's just something that the hospice company will cover themselves. And then finally, it includes bereavement support. So bereavement support, I believe, should be provided for up to a year with routine check-ins. Thankfully, the hospices that I've worked for did this, but sometimes this service can fall through the cracks. Some hospices also have additional services like chaplain, music therapist, a volunteer coordinator, volunteers to sit with patients or provide specific services. And I've also worked with hospice companies that employ specific bereavement coordinators, specifically so that that role of support does not fall through the cracks. And then we have palliative care. So this is for a serious illness at any stage. This, like I said in the previous slide, can be alongside curative treatment. So you are able to still see a specialist or provider if you're on palliative care. This is often, care is often provided in hospitals or clinics. Coverage varies by insurance. And then again, similar to hospice, the focus is on symptom management. Home health, which is different from hospice and palliative care, is supporting end of life at home, but it's a step up from hospice care. So again, you still have those skilled nurses, the professional medical care. They provide medication management and wound care. You have the personal care, which is the home health aide. We also have that within hospice. And they provide assistance with bathing, dressing, daily activities. Physical therapy is also provided, so making sure that you're able to complete those ADLs as daily living tasks. So maintaining mobility and comfort, and then social work. So connection to community resources and community support, emotional support as well. So advanced care planning, I want to go over a couple of benefits and barriers to advanced care planning. So some of the benefits can include peace of mind. So knowing that your wishes will be respected. This is not always the case, however, but at least having something in place is important for making sure that when you are able to, you are documenting what you would like done. This can also reduce family burden. So family members don't have to guess your wishes. Again, if somebody's coming out of nowhere, a family member that may be estranged or a friend that may say, oh, you know, they didn't want this. If it's written down, if it's been documented, they did this themselves. They practiced their self-autonomy. It's there, and it can reduce that burden on the caregivers. Providing appropriate care. So this can help ensure that treatment aligns with personal values. And then finally, that medical guidance. So you're providing a clear direction for the healthcare providers. Again, we just want to make sure that it's in writing. It may not always be the case, but it can help make sure that your providers know what you want in a certain situation. So some barriers. to end of life planning. Psychological barriers, so fear, avoidance. In some cultures, death is taboo still to talk about. So we need to be mindful of this as providers. Knowledge gaps, so lack of understanding about options and processes. If you don't work in the medical field, you don't know a lot about these terminology, you don't know a lot about what's your options are. My research is really built around providing information and education to rural communities about what all is entailed in end-of-life planning and advanced directives, because if you don't work in that field or have somebody that works in that field, there's a lot of information you don't know. And a lot of the communities that I served, they would come on to hospice with me and they didn't know what their other options were. So knowledge gaps is a really big barrier to end-of-life planning. Family dynamics, disagreements, estrangements, communication difficulties, and then procrastination. So perception that there's always going to be time to plan later. I'm in my 30s and I have a living will. I have all the things, a medical power of attorney, I'm my father's power of attorney. And again, it's because I work in this field, but also I didn't want it to be too late if something were to happen. We have something in place. And I'll get into that a little bit later, but it's not a contract. You're not bound by it. It's ever changing, it's ever flowing as you age and as you go through a life. Okay, let's see. Okay, so let's transition to talking about types of advanced directives, which I discuss in more depth towards the end of our presentation and provide information on where you can find these specific advanced directives. But very briefly, I want to talk about living wills, medical power of attorney, do not resuscitate orders, and POLST forms. So our living will specifies medical treatments a person would or would not want if unable to communicate. These could also go in more depth. They could talk about assets as well. Medical power of attorney, it designates someone to make healthcare decisions if the person cannot. So as I stated, I'm my father's medical power of attorney. I'm also his financial power of attorney. He is married to my mom, but we don't have to get into that. I think I'm a little bit more responsible. So that is why I am responsible for that. Do not resuscitate order. This instructs healthcare providers to not perform CPR if breathing or heartbeat stops. So it is not, I like to say this a lot in my presentations, CPR is not as glamorous as it appears on TV. And what I mean by glamorous is when somebody's getting CPR done on them, they have stopped breathing. They are no longer living. They are dead. Their heart has stopped. And to get the heart pumping again, there has to be a routine amount of pressure put on that heart. That's why you see in shows and TV, they sing it to a song, like, but you're going through the sternum and essentially you're having to go through bone to get that heart to start again. So when you're on hospice, if you have a do not resuscitate, when you die, the nurses, the social worker, whoever is there is not going to perform CPR. I've had patients that did not want to do not resuscitate. They have been declared dead, but we had to perform CPR on them. It's very devastating sometimes for the family because when we're doing it, we have to do it until the ambulance and the EMTs get there. And then they are required for 20 minutes to do it as well. And most of the time they do not come back to life. So I like to specify that because it's on TV, it's like, oh, they did CPR and they're back to life. That's not how it goes in real life. And I'm happy to talk more about that if you have any questions, put in the chat about that. POLST forms, these are physician orders for life-sustaining treatment forms. These are specific medical orders for serious illness. So most physicians, many of your PCPs should have this. If you just ask them, they can provide this for you. This is a medical DNR, sorry, not a DNR, a medical POA as well. It just deems what you would like done. Okay. So the ideal timeline for planning. So we have middle age. Create your initial advance directive, discuss your values with your family, select your healthcare proxy. So who would you like to be in charge of your healthcare if you are no longer able to make decisions for yourself? So the ideal timeline is around 40 to 60. Early retirement, between 60 and 70. So review and update your documents, consider long-term care insurance, and discuss your preferences with your doctors. Later years, later retirement, 70 plus. So regularly plan your reviews of your documents. Be more specific about your medical directives. Have more family discussions about specific scenarios. And then finally, serious illness. So implement palliative care if needed, review hospice eligibility if needed, and ensure that your documents are accessible to providers. Okay, so how can we support persons living with a terminal illness? Maybe they're not on hospice. Maybe they've had this terminal illness for a while. How can we support them? Or how can we support our older adults as they're aging? And feel free to unmute or put in the chat. I will open the chat so I can see. Yep, so having honest conversations, listening to them, focus on dignity, hope, and peace. Yeah, help them understand what is available to them, give them respect and dignity, and ask if they need help rather than just doing things for them. Yep. Listen, yep. Meet them where they are. Yes. Yeah, so let's see. Um, So understanding that it's a journey. Nobody wakes up with a terminal illness and is just, this is my life now. I'm going to be accepting of this. It's a journey. So terminal illness creates a profound physical, emotional, and spiritual challenge that evolves over time. Each person's experience is unique, influenced by their medical condition and their symptoms, their personal beliefs and values, their support system and their relationships that they have, and then their previous life experiences. So, as caregivers, understanding this journey helps us provide more meaningful, person centered support that respects the whole individual, not just their diagnosis. Terminal illness affects the whole person, the physical, emotional, spiritual, social, every dynamics, every system of that person. So holistic care can address all of these dimensions. So honoring autonomy and self-determination, I saw a few people in the chat mention like listening to what they want. This is really important. Informed decision making. So we want to provide clear, honest information about diagnosis, prognosis, and options. We want to use plain language and visual aids when helpful. We want to verify that they understand, so that we want to use reflective practices. So if we're telling them, this is what's going on, this is your prognosis, this is your diagnosis, repeat back to me what you understood out of that. That is helping them to have informed decision making. We want to encourage them to engage in an advanced care plan. So encouraging them to complete documentation of their wishes, revisit these discussions as conditions change. So as I said, it's not a contract. You're not bound by it in that moment. It is ever evolving. You may decide that right now I do want to have some of these treatment measures done if I become in a state where I can't make decisions for myself. I may want, we call it tube feeding. in medical terms, but you're getting nutrition through a tube because you can't chew or you can't swallow. You may decide later on, I don't want that. I don't want you guys to do that to me. That's an ever-changing advanced directive. So keeping up with these conversations. And then daily choices. So honoring the preferences and daily routines, whether that's for food, whether that's for visitors, how often you want people to come see you or to come help, and your environment. So small choices really matter. They matter a lot when control over health is diminishing. People with terminal illnesses don't lose their right to make choices. Our role as providers, social workers, clinicians, whoever we may be, is to provide information, options, and support. We are not here to decide for them. When cognitive impairment affects decision-making, we need to follow previously expressed wishes and consult those designated healthcare proxies. And we may need to still involve the person to whatever extent possible. So some cultural considerations for end-of-life care. Cultural background is profoundly influence how people understand illness, how we make decisions, how we express pain and approach death. These differences can extend to communication about diagnosis and prognosis, decision making. So is this a family decision or is this based on the individual? There are some dynamics at play that we need to be cognizant of. Religious and spiritual practices is a big thing. And then expressions of grief and mourning rituals. So providing culturally responsive care requires humility, curiosity, and a willingness to learn from that person and from that family and from that community. So rather than making assumptions based on a perceived cultural background, we should be asking questions as practitioners like, what would be helpful for me to know about your cultural or spiritual traditions as we plan for your care? What would be helpful for me to know about your family? Who do you prefer that I speak to? Would it be you? Do you have someone else? Instead of coming in with an assumption. We want to create a supportive care environment when we're working with older adults and when we're working with adults with a terminal illness. We want to provide physical space. So creating a calm, personalized environment with familiar objects, photos, adequate space for visitors. We want to minimize the medical equipment that's visible while maintaining accessibility. We want to create a routine and predictability for that person. So we want to establish consistent care routines while remaining flexible. We want to provide a visible schedule of medications, treatments, and visitors to reduce anxiety and increase the sense of control. So as I mentioned in a previous slide, as control over what's happening with our health diminishes, we want to make sure that we're providing control for those persons where they can have it. So if that's in regards to, oh, I only want people to come before 5 p.m. I don't want any visitors after 5. Let's give them that. And then finally, communication. So have these important conversations at times when the person is most alert. Position yourself at eye level, minimizing distractions, and use simple language. So I would not be, as a social worker in hospice settings, there was never a point where I would have a conversation with a family member where I'm standing and they're sitting. I would ask if I could sit down, and I would be at eye level with them so that we're on the same level. We're having the same conversation. That sort of diminishes that idea of there's a power dynamic there. I'm the one that holds the information, so I'm up here. You don't want to do that. You want to have the same conversation with the person at their level. And that's some stuff that we don't often think about, how important that can be.
Hey, Chesney, there's a question here in the chat. Someone's asking, how do these directives need to be written up to be legally binding? And they're talking about a will, power of attorney, advanced medical directive, etc. How can that be done for someone who has financial limitations, especially where they need to be evolving and adaptable to the person's change of situation and preferences?
Awesome question. So At the end, I'm going to go over some of the advanced directives that are free, that are abiding in every state, and you don't need like elder attorney, or like, so for example, 5 wishes, you just need 2 witnesses and they can't be family. Like just have your neighbor witness and sign or whatever. But I will go over some of those because finances is a big thing with getting things notarized and getting things legalized. So yes, I will go over that. Did that answer their question?
Yes, thanks, Chesney.
Okay, perfect. Okay, some special considerations for older adults. So some common challenges include multiple chronic conditions. So this can complicate symptom management. So if there's more things going on, whether it's mental health, in addition to their terminal illness or pain, that can be a challenge. Medication interactions. So again, if there is a mental health diagnosis along with a physical health diagnosis of pain management over here, but also we've been treating this mental health diagnosis for years, there can be some medication interactions. So that requires really careful pharmaceutical review. Sensory impairments. So this can affect communication and engagement, cognitive changes. So this impacts decision-making capacity, social isolation, outliving friends and family members, especially, when we are working with rural communities as well. They're already isolated from a social environmental standpoint. So being mindful that this could be a really special consideration for our older adult populations who live in these areas. And then finally, financial constraints. So fixed incomes, limiting care options. So I had mentioned in some previous slides about how you can have care in like an assisted living or a skilled nursing. Well, if you don't have insurance to provide that support, you're paying out of pocket, and many of us cannot afford that. So being mindful of that when we're working with older adults, how we can support them. So some essential resources for people with terminal illness: hospice and palliative care services. I talked about those in a couple of other slides. Legal and financial planning. So elder law attorneys, financial advisors that specialize in end-of-life planning, Social Security for death benefits, and then our local area on aging. A lot of our older adult daycare agencies, we can always ask them for any information that they may have to support us when working with older adults. Emotional and spiritual support. So counseling services that specialize in grief and terminal illness, chaplains, spiritual leaders from preferred faith religions and traditions, and then support groups for specific conditions, whether that be cancer or ALS. Excuse me. And then practical daily assistance. So home health aides through Medicare or Medicaid, meal delivery services, Meals on Wheels, or if you live in a community where your faith community provides meal services for members, and then transportation services for medical appointments. So, and then respite care is another option. So one thing that you can do as a practitioner that is helpful is create a resource binder with contact information, eligibility requirements, application processes. This can help reduce stress for you when you're going into a home or going to see a client or a patient or an older adult. You already have all of this information already ready to go. It can reduce stress for you and reduce stress for the family. So when you're being asked a question, oh, let me pull out my resource binder. I'll have the answer for you. And then being compassionate, like we're all on this meeting together because we want to do better by our older adults. We want to know more. We want this education. This is the first step to being compassionate with older adults who might be in crisis, who might just be getting older and just have limited resources available to them. We want to honor their autonomy. We want to support their choices. We want to respect their preferences, even as capacity changes, and we want to advocate for them. We want to approach every person as an individual and be person-centered, especially when cultural influences come into play. We want to care for their physical symptoms while also attending to their emotional, social, and spiritual needs. And we want to help them navigate the complex healthcare system. So we want to be able to connect them to the appropriate people. If we don't feel like we can help them, the best thing we can do is refer them out. This is part of that continuum of care. If I can't help you, I'm going to make sure that I can get you to someone who can. And then I love this quote. How people die remains in the memory of those who live on. Creating the conditions for a peaceful, dignified death is one of the most meaningful gifts we can offer. As a hospice social worker, I would often get told, oh, it takes a special person to do this. It takes a special person. No, what's special is the fact that these strangers are allowing me to come into their home and look after them and make sure that they're okay in a time where they're their most vulnerable. So it's not me being a special person. It's the fact that I'm being trusted is what makes it more meaningful for me. And I tell my students, if there's ever a point in social work where you feel like you're getting burnt out on the job you're doing, do something else. Because the job you're meant to do is the job that is going to wear and tear on you. Take a 6 month and do something else and come back. I digress. Okay, so let's shift gears. How can we support caregivers? What can we do to ensure that we are supporting the family as well as the patient? And you can put it in the chat or you can unmute. But shifting gears, how can we support our caregivers? Last time I did this, I lost my thing. Hey, Erin, do you mind reading it? Because last time I switched my mouse, I lost my mouse.
Absolutely, yes. So we have a few comments so far. Checking in often. Someone said it's the same, listening to their concerns, check-ins, being aware of resources in the community for support, letting them know it's okay to not be okay with the situation, understanding their limits.
I love that. Yes. So just like the patients, the caregivers have a journey. So let's talk about the journey to becoming a caregiver. First of all, we have to understand it's a journey. If you don't work in the medical field, there's a lot that we don't know. So making sure that we're allowing time for that initial adjustment, allowing time for the caregivers to take in what we as healthcare professionals are telling them and supporting them. We need to allow them to ask questions, be emotional. Essentially, we need to navigate those stages of grief. So denial, anger, depression. We need to acknowledge that they're going to go through all of these things when their role is shifting. We want to help them find balance in their new role. So many of us are what we're called the sandwich generation. So this refers to adults who are caring for their aging parents or loved ones, as well as their own children. I've had to do this many times. I've taken care of my grandfather. I've taken care of my father. I'm taking care of these bad kids over here. They're screaming at the door. So we just have to consider that caregivers are working. We're working individuals. We have things going on. So we need to help the people that are put into this new role find a balance between working, caring for their loved one or friend, providing them with resources and support. And this can be challenging, especially if finances are tight. So we also need to be mindful of that. We need to have gentle conversations. And then we need to provide resources. Support is essential. Education, connecting them with the community and agencies around the community that can support them. And then finally, providing meaning to the role of caregiver. And this sounds really cheesy, but it is what it is. It can feel like a burden. And sometimes it can feel like a relief when that loved one dies. These are normal, okay feelings to have. But if we find meaning, whether that's honoring the loved one who may have cared for us when we were younger, or just wanting to be a support to someone because they have no one else, whatever the reason is, find some sort of meaning to helping those caregivers, help them to find meaning in their new role. That can make the role a little bit easier for them. Okay. So caregivers take a significant toll. Caregiving takes a significant toll on mental health. This pie chart is just an example of the types of mental health concerns that we have for our caregivers. Nearly 70% of caregivers report clinically significant symptoms of depression. Along with that, so with depression, it's often undiagnosed within our older adult population, and it may present differently. So to be more specific, depression in older adults could look like physical complaints, cognitive difficulties, whether that's forgetting things, no matter how big or small, like the name of something. You know, you could be drinking, like this is a Red Bull. They might forget that name. Or changes in behavior, social withdrawal, mood changes. We also have anxiety. This is common with health changes. So this can also worsen physical symptoms. I mentioned earlier, we have to treat the physical symptoms as well as the mental health concerns. You know, as pain increases, anxiety can increase. So being aware that this is a common concern with our older adult population. Grief, so multiple losses are very common as we age. And this can complicate our grief as well as we age and require more specialized support. And then finally, cognitive changes. So distinguishing between what's normal, aging and depression and dementia versus what's not normal. And then each of these requires different approaches. So there are mental health considerations these are just a couple. Can any of you all think of anything else to consider that maybe other practitioners may not have thought of when working with older adult populations? And you can put it in the chat.
Someone in the chat said suicide risk.
Yep.
People are saying isolation, social isolation that comes with memory loss.
Yeah. Suicide risk is a big one.
Anger or rage as a response to aging.
Especially when you start losing autonomy and you start not being able to do certain things. So these are a few ways that we can support our caregivers. There's way more, but for time purposes, I only included a couple. So respite care, which is arranging temporary care to give caregivers a break. These breaks can prevent burnout and sustain caregiver ability. Respite care, if you're on hospice specifically, is covered. It's 5 days in a skilled nursing facility that the person can go to and the caregivers can have a break. We also have support groups, which connect caregivers with peers facing similar challenges. So sharing experiences, reduces isolation, provides practical tips. So even in this space that we're all in, yes, I'm giving information that I'm sure a lot of you have. This is, to me, is like a supportive network of people. We're all trying to do our best to serve this community. Education, so providing training on care techniques and coping skills. Knowledge increases confidence and then reduces anxiety. And then finally, mental health resources. So this offers access to counseling and therapy services. Professional support helps process grief and manage stress. Okay, so we also need to consider the extended family, the extended friends, as well as beyond the caregiver themselves. So we need to be knowledgeable about anticipatory grief. Family members and friends often experience grief before the death even occurs. This is normal. It's okay. It can be confusing and isolating, especially we all grieve in different ways. So just being knowledgeable that anticipatory grief is possible is one way that we can help support the people that we're working with who are caring for that dying individual. Role changes. So family dynamics shift with caregiving responsibilities. So like that sandwich generation I was talking about, children may become caretakers. Children may start parenting their parents. I know I'm on the phone with my parents almost every day, parenting them about some of the silly decisions they think they should be doing. And I'm just like, no, don't do that. Decision fatigue. So constant medical decisions can create emotional exhaustion. Again, this is why having a clear advance directive may reduce that that burden of decision making. And then finally, post-care adjustment. So after the death occurs, the caregiver faces identity changes. Their daily routines and their purpose shifts. So if your identity shifted to becoming a caregiver, just like when you have children, your identity shifts to being a parent. If you're no longer, when your kids go off to college, you're no longer having to parent every day. If you're caregiving for someone who's dying and has a terminal illness and they die, your role shifts. What do? You're left in confusion. And so making sure that we know this as practitioners and we can support them through this transition is really important. So cultural considerations and end-of-life care are really crucial for providing respectful and effective support. There are diverse beliefs about death and spiritual practices. You may have noticed throughout this presentation, I have said death and die and dying. Others may say passed away or moved on or transitioned. It's a preference. So being mindful of what one's culture's preference is important when talking about end of life. So many cultures have specific rituals around dying. So understanding these helps us providers support these families appropriately. Communication styles may vary. Some cultures prefer family-centered decision-making. Others have taboos against discussing death directly. Family roles may be different. So expectations about who provides the care can vary widely. So consider extended family, friends, and community roles, all of which can significantly impact a patient's experience with us. So by understanding and respecting these cultural nuances, providers can improve patient satisfaction and ensure care aligns with individual values. Some other key considerations around cultural differences and death and dying. What could those include? Any thoughts on that? And feel free to unmute because I can't see the chat. And my question was, any other considerations around cultural differences and death and dying?
I know, Chesney, I've heard that some different religions have like different beliefs about how quickly someone needs to be buried after they pass. So I think that that can be something to be, it's important to be aware of because there might need to be more advanced planning in those situations.
Yeah, great point. So I worked with a hospice company in Michigan, and I think they were so great. We were so culturally aware of our populations. And you could see it from the other side. We were just like, I don't know, but I saw it as very culturally appropriate. We had a Jewish care team. So we had a rabbi, a Jewish social worker, and Jewish nurses, and they cared for all of our Jewish patients. We had a Black woman, and I was on the Black team because I'm Black, but we had, you know, specific care teams for specific religions based on the area of Michigan where we worked, because Michigan has a very large immigrant population up in northern Detroit. And we tailored our care teams to that specific population. Not to say that we all didn't cover for each other or whatnot, but yes, Aaron, great point, because with uh, I don't want to botch it. So if anybody here is Jewish, please correct me, but they sit Shiva. So they don't bury their loved one immediately. And everybody comes and gets to see it. And it's a whole cultural thing. And being aware of that, and that is not my expertise, and that they hired a specific social worker for that, I was like, wow, this company is great. Like, this is awesome, because there was a huge population where I worked where they needed somebody from the culture to understand how they understood death. But yeah, any other thoughts?
Yeah, there's two good comments in the chat. One person said, never assume you know somebody's culture. Even if you come from a similar background, your beliefs can be different. And there's another comment that said, different beliefs on what medical care to seek, for example, blood transfusion, assisted suicide, etc.
Yeah, yeah, great points. Um, if you ever want to pick my brain about assisted suicide, I have my contact information, and the last slide, I did a whole like paper on that when I lived in Michigan, because it's not legal when I was in Michigan. But there are ways in which to get around it ethically. There are, because a patient, if they're in decision making, can refuse care. And I had a patient that had ALS, and his oxygen was what was keeping him alive, keeping his breathing steady. And he wrote down, I want to be taken off of the oxygen. And the hospice team said that they would do that. So if you ever want to chat with me about it, I can tell you more specifically. But yes, everything that you guys are saying. So there's taboos about, you know, death might be a taboo subject. So, you know, people might not be open to having conversations about end of life. There's differing views of like the afterlife. So cultures vary in their beliefs about what happens after death, including reincarnation, spiritual journeys, or continued presence. There's difference in suffering. So, you know, cultural backgrounds influence how people perceive and cope with suffering and pain. There's also those differing cultural values and family hierarchy, you know, and role of who's going to be the caregiver, decision making. There's obviously language barriers. And then there's these like indirect communications that I've come across where like some cultures prefer indirect communication, which is like more sensitive and patient approach. And like, do they want to be at home, or do they want to be in a nursing facility? Some cultures prefer the person stays at home, where some cultures might feel like if the person dies at home, that's not a good thing. Like if they're about to die, send them to a nursing home or send them to the hospital. We have to understand these nuances before making any decisions, because it's up to the patient and the family. Okay. So how can we support families in having these difficult conversations? Choosing the right moment. If you didn't learn anything from me today, take away this point. Choose the right moment to have this conversation. Don't have this conversation when your family is in crisis. Don't have this conversation when when mom's at the hospital and dad's hysterically crying, everything is in chaos. Have the conversation during calm periods. Allow plenty of time for questions, for comments, for feedback. Don't rush through it. Choose the right time. Listen more than talk. As practitioners, as healthcare providers, it's very important for us to listen. We need to hear what they want. We need to hear what they are choosing to do, what they don't want to do. We need to let that person and that family express their wishes and their values and what is important to them. So asking open-ended questions. So we want to focus on the values and not procedures. So discuss what made life meaningful for them. What is making life meaningful for you? What do you value in your life? What is important to you? Technical medical details can come later. We don't have to use these fancy words of do not resuscitate orders and medical power of attorney. We can just talk about values, simple layman's terms. And then finally, document and revisit. So as I've been saying this whole time, write down the decisions, but review them periodically. Preferences can change. You may want to change who's in charge of your healthcare. That's totally fine. Just change the document.
Chesney, there's a great question in the chat. Someone asks, what advice would you give if the family didn't set this up beforehand and the parent's dementia has progressed to the point that they can't fill out power of attorney, but the parent is aggressive about having any help, but not safe at home?
So I would consider at that point getting guardianship over that parent, which again, one of the earlier questions was about financial strain and doing this, but at that point, getting guardianship, and you have to go through the court and everything for that. That way that they can make decisions and make sure that that person's safe. And if it's like crisis, if it's crisis mode, making a referral, like call the police and do a wellness check and have them go see what's going on so that they can see themselves, like this person is not safe in their home by themselves. But yeah, I would suggest trying to get guardianship so that you can make those decisions and make sure that they're safe.
Do you know how long that process usually takes?
So I haven't done it here in Utah. I would say in Tennessee, the quickest I had someone get guardianship over their loved one was like 90 days. The quickest. About the same amount of time that it takes to even get a notification from Medicaid if you're applying for Medicaid. So if you know you're going to need some of these services now, start that application. So these are just some resources. How many more slides? Oh my gosh. Okay, so these are some resources that I wanted to provide for guidance through end-of-life processes. Many of these are free. They're available online or through your healthcare provider. I'll go over some of these a little bit more detailed at the end with the websites where you can find them, but I just wanted to go over some of them right now. So one is the Conversation Project. It's an online end-of-life planning resource guide. We have AARP, Advanced Directives. So these are organized forms to document your end-of-life wishes. The National Hospice and Palliative Care Organization has professional resources on their website for end-of-life care. There are caregiver support apps, which are digital tools that help us prepare for end-of-life planning. And then 5 Wishes. I touched on that a little bit earlier, but I'll have a slide on that. That's a comprehensive document for expressing medical and personal wishes. It's online and it's also printable and it's also acknowledged, I want to say, in almost every state. And it's a really great resource. It gets really detailed. And that is one of the ones you just need witnesses for it. It's a legal, upstanding document. You don't have to get it notarized. You can get it notarized if you would like, but you can also just have witnesses sign it. It can't be related to you or have any, they can't be a recipient of any of your assets. Okay. So effective end-of-life care requires a team approach. So coordinating between providers, this ensures regular communication. So we have medical support, which is, our primary care physicians, our specialists, like our oncologists, our palliative care team, our hospice nurses, our social workers. We also have to be mindful of the social emotional support that we have to provide. So counselors, support groups, chaplains, community volunteers. Our practical supports are home health aides that assist us with the bathing and the cleaning of our loved one, meal services, transportation services, respite care, adult daycares, and then finally financial and legal support. So those elder law attorneys, those financial advisors, insurance specialists, and again, social workers. Okay, so just some key takeaways before I transition into some of the applicable tools that we can use. So again, start early. Like I said in the very beginning, I'm in my 30s. I love working with older adults. It's been my bag from the beginning. And after working with this population for so long, after having my kids, I thought I need to have these directives in place that I'm telling my clients to have in place. So start early because it's ebbs and flows along with life. You can change it. It helps reduce anxiety and it normalizes talking about it. I don't have a terminal illness, but talking about what I would like done if I were to die unexpectedly helps normalize it with my family, with my friends. So I really want to emphasize that. Support our caregivers. So recognize when your caregiver needs respite or needs support or needs emotional support and understanding that they're on a journey themselves, and supporting them through that. Respect cultural values and norms and differences. So approach end-of-life care with cultural humility, and then focusing on quality. So again, end-of-life care is more about quality of care versus quantity, years lived. It's more about how are these final years going to best serve you? What do you want? What are your values? How can I help you? How can I support you? So understanding that. So really quickly, I just want to go over some tools. Some of these I've listed. So let's see. So Prepare. This is a free, user-friendly online platform with two main programs. So it's Prepare for Your Care, which focuses on helping individuals complete their advanced directives. And then there's Prepare for Their Care, which is a resource for helping loved ones with their end-of-life planning. This empowers individuals to understand medical information and make informed decisions. So, and I can put all these in the chat after as well if needed, but the website here is prepareforyourcare.org. We also have Voicing My Choices. So this is a tool that my research assistant Adele found when we were looking at how to engage young adults in end-of-life planning. So based on feedback, Voicing My Choices was a really great tool for young adults and adolescents who had a terminal illness. They felt like this was a really great tool for them. So they have My Choice checkboxes, My Voice, open-ended sections. It's very age appropriate for young adults and teens. And it really helps young people communicate their end-of-life preferences to their friends, family, and caregivers in a developmentally appropriate way. So if you just Google voicing my choices, excuse me, there's a packet that you can download and it's in PDF form. And then we have 5 Wishes. So this is legal. It's recognized in nearly every state as an advanced directive document. It's comprehensive. It goes over personal, spiritual, medical, and legal wishes. I know the website's small, but I can put it in the chat, like I said. And it's available online or as a printed booklet. And then it's designated for anyone 18 and older, making it appropriate for young adults. So that's kind of where my research is headed. I love working with older adults, but I want to see if I can engage young adults more into talking about end-of-life preferences, as the sandwich generation ends up taking care of more older adults. Okay, PULSE forms. So physician orders for life-sustaining treatment. So this is a standardized medical form. You can typically get this at your physician's office. They should have this. It covers CPR, scope of treatment, and then artificial nutrition and hydration. So as I mentioned way back about the tube feeding, we call it tube feeding. That's artificial nutrition and hydration. So if you want to get artificial food, if you're no longer able to swallow or chew, you can designate that on your PULSE form. This is available in every single state. And then here's the website here, pulse.org. And then finally, we have the Conversation Project. So the conversationproject.org is where you can find this information. This is a worldwide public engagement initiative focused on helping everyone talk about their wishes for end-of-life care. So there's free resources for starting end-of-life conversations with loved ones, choosing a healthcare proxy, which is someone who you want to take care of your medical decisions if you're unable to, and then resources on how to talk to family members that may have a serious illness. And that is it. That's all I have. Woo -woo. I'm on time.
Thank you, Chesney.